introduction. He is not only an attending physician of epilepsy and neurology. There's a slide right there. It tells you exactly where he's from. But he's also the chair of our Medical Advisory Council. And when it comes to the topic of transition, he is the person that I think of to have this awesome conversation. So I hope that you all find this to be as informative as did I. And again, please enter your questions in the chat, and Dr. Millichap, I turn it over to you.
All right. Thank you very much, Ayesha. Thank you all for joining us tonight. So I am a member of the Transition Program Action Committee that is convened by the Child Neurology Foundation. And so these slides are taken directly from the Child Neurology Foundation website and feature some of my patients from Lurie Children's who agreed to share their stories with the Child Neurology Foundation in 2017. I think it's nice to have case studies that will exemplify the process that has been developed by the Child Neurology Foundation for transitioning specific to epilepsy. I'll just check there that everybody can hear me okay.
Yep.
All right. So the Child Neurology Foundation, you may not know, is associated with the Child Neurology Society. They have several projects going on, and they will convene different stakeholders to tackle different advocacy issues. They bring everybody together, industry, families, physicians, and will host the resources on their website or in some other form in order to improve the community. And as I mentioned earlier, the Transition of Care Program and the Transition Project Advisory Committee that I'm a member of has developed these different tools for assisting transition in our epilepsy patients specifically. There was a publication in 2016 and this outlined the 8 common principles that we're going to go over today, and is really an epilepsy-specific version of something that's already produced for general pediatrics that goes by the name of GOT Transitions. And like Child Neurology Foundation, the TPAC brings together all of these different stakeholders or members of the community that are involved, and also connects to, in blue here, the other professional organizations that are involved in epilepsy and neurology: the American Epilepsy Society, AES, Child Neurology Society, CNS, American Academy of Neurology, AAN. So there's a website here, childneurologyfoundation.org transitions, where you can find all this information that we're going to go over, and it's all freely available there, and an introduction from Ann Tilton, who heads up the TPAC. So we're going to go over in detail these 8 common principles of transition. So this first thing you'll see on the website is a interactive graphic that will go over the 8 common principles, which are expectation of transition, the yearly self-management assessment, annual discussion of medical condition and age-appropriate concerns, evaluation of legal competency, annual review of transition plan of care, child neurology team responsibilities, identification of an adult provider, and the transfer is complete. As I mentioned earlier, there's 2 families that contributed to this work, and the series of videos, I took excerpts from the videos and inserted them into this talk to help give the parent and patient and caregiver perspective. So as I mentioned, we're going to emphasize how to use the 8 common principles. So you can see here on the infographic the 8 principles that I just talked about, and we're going to discuss the tools that are associated with the principals, and we'll go over what those tools are, worksheets basically, that help us to organize this transition process. So the first case is Kobe. He's a patient with well-controlled epilepsy. He has typical development, and after transition expected to live independent of his mother. So he's 18-year-old. He had focal epilepsy. He had seizures that started when he was 15. His evaluation with an MRI and EEG were normal. He had one seizure medication which worked unless he didn't take it, which is not uncommon in teenagers. And here's some of his initial statements.
The sound on the video is not coming through, unfortunately.
Oh, pardon me for that. Not sure how to
Yeah.
that. But he talked about how he, didn't take it seriously at first. He, had wishes to play football professionally, and the epilepsy was a real shock to his system. So what age? I'll have a couple questions laid in here, which are rhetorical. I guess I'll answer them for all of us. But what age would you complete the transition? So 16, 18, 21, or 25. So I think, that gives a broad range. Obviously 16 is probably a bit young in most people's minds. 25 might seem more realistic for others. Ideally, we shoot for before the 22nd birthday. So the best answer here is 21. So Kobe's expectations. So we start off with the first couple of principles here, the expectation of transition. So really we want to introduce the idea of transition as early as 12 years old. So if your doctor starts talking to you about transition at the age of ascent or 12 years old, that's not because they're pushing you out the door. It's because it's good practice to disclose to you what the process will be. And so we have enough time to prepare and to have the all the steps in place to make a successful transition. And you'll see at the bottom of each of these principles, there's a couple little boxes. On the top one, transitions policy and transitions checklist. So these are the tools I was referring to, or the worksheets, and we'll go through those in detail as well. And the yearly self-management assessment. So we have this checklist. You'll see the tools are sometimes presented in both of the principles, or in many of the principles. And in this case, Kobe can probably assess himself. So he'll fill out the self-care assessment. And in our second case, where the person with epilepsy is unable to speak for themselves, a caregiver will fill it out for them. So here are the actual worksheets, or the tools. On the left, the transition policy. So this is an example of what a epilepsy practice might present to a family at age 12 or even sooner. Around the age of 12 or 14, we'll start introducing the idea of transition and lay out the different steps that will go forward in order to complete the transition before age 22. And clearly stating what the family's responsibilities are and what the doctors and the clinic's responsibilities are. The document on the right is this checklist, which kind of goes through, did we talk about the transition policy? Check mark, date. And then all of the other things that we're going to discuss, the readiness assessment, the medical summary, adult model of care, and then finally the transition packet. So this is an example of the self-care assessment. So Kobe would check out these boxes and do this on an annual basis to see that he's moving through the stages. If he had checked on one instance when he was 14, he checked off, I still need to learn what medicines I should take and what I shouldn't take, or what I'm allergic to, then the next year we would hope, yes, I know this would be the answer. And so by the end, this will become sort of repetitive, and we'll be sure to have covered all of the topics by the end of transition. So it's fairly straightforward, but a little bit repetitive, and but I think it's good. It's funny how a year flies by, and you'll be able to remember what your answers were in the previous year. So here's where mom suggested that the process of transition is difficult, and that it's important to start early, and that she appreciated the tools that were available from the Child Neurology Foundation. And the next principle, 3, 4, and 5 are principles. First, a medical summary. So again, we'll use the transition checklist and the self-care assessment in order to develop an idea of what are the medical issues surrounding that child. And next, the evaluation of legal competencies. So sometimes it's very clear. Kobe will be able to make his own medical decisions when he turns 18 and becomes, no longer legally a minor. But in some other cases, it may be, more difficult to understand that. And you will be able to address that every time that you will see the doctor and address the transition issue. So it's sure important to have a formal assessment early enough, rather than when the child is 17 and a half. If there's some question, how much information they'll be able to handle as an adult, or function as an adult. And then the annual review of transition plan of care. This is where we write out, what are our steps? Are we changing medications? Are we doing tests this year, for example? And now a bit about the next principle, the child neurologist team's responsibilities. So as a child neurologist, these are some of the issues that I think about when I'm planning about Kobe's transition, or another one of my patients is, where are they going to go? Or are they going to be okay? Are they going to feel comfortable with their new provider? And I'll discuss in the clinic the timing of the transition. Are they going to move to a new city and probably live there because whatever industry they're going into is based there? So maybe go to college there and then continue to live there. Are they going to go to college at all? If they're going to go to college, will they have infrequent visits with me once a year, for example? And what is the insurance status as they get older? I think a lot of insurances continue until 25 now, but this is constantly changing. And like with all chronic diseases, encouraging the ownership of the medical care. So really starting to interview Kobe more and more as he gets older about what medicines he's taking and what he thinks about his own health. And then the plan of care tool or worksheet. Here, as I had mentioned before, the goals for this year. What matters most to you as you become an adult? So we write these things out, and it's sort of self-fulfilling, target date and completed date that we hopefully will take care of that. And what is the adult neurologist thinking? So they should recognize that the patient is probably leaving, somebody that they trust and that they've worked with, hopefully, well, and that they are reluctant to leave. And the adult neurology practice approach to patients is different. More specialty-driven care, meaning in a pediatric neurology clinic, we may take care of more than an adult neurology clinic would, as far as helping to coordinate other specialists, making referrals, assistance with the things that you may take for granted, as far as writing prescriptions for non-epilepsy or neurology specific related things. And I think this will vary from practice to practice. I'm lucky to live in or work in a large hospital that has a lot of subspecialists, and a lot of those specific tasks and tools are taken out by the experts rather than myself. But at some pediatric neurology clinics, they will certainly take care of more of this themselves. And then you can point out a referral to a new adult neurologist, but there may be a difficulty traveling to that location, or they may not accept the insurance. It's quite possible. So this is an example of a letter that myself or child neurologist might send to an adult neurologist. So, dear doctor. And we might say, we include all of these different aspects: the medical summary, emergency care plan, list of medications, specialists, transition readiness, the legal status as far as competency, and offer to discuss this in person or at any time after the transition has been completed. And here is more contact information and sort of concrete things that the new clinic may need. A lot of this is covered in the electronic medical record and can be sort of printed out, but it's good to make sure that all this information is included at some point. So here's another question just to solidify these aspects. So what's included in a comprehensive transfer package? The transfer letter, self-care assessment, plan of care, and updated medical summary and emergency care plan. So in this case, it's all of the above. So the video is playing again, and Kobe is just discussing how he has taken epilepsy and realizes it's a part of him going forward as an adult, and he's ready to make the transition to adult care. So I'm sorry we won't be able to hear Katie's mom talk about her experiences. I'll have to make sure or try to add that into the video afterwards somehow. But case 2, or Katie, is a patient with a complex condition. She has intellectual disabilities, and she's not expected to live independently after the age of 18. So she's already 23 at that point, and she has a diagnosis of cerebral palsy, epilepsy, and other medical issues. She had low tone, meaning she was sort of floppy or not holding up her head well, and her legs kind of moved around very easily, and had delayed developmental milestones, meaning she didn't sit and walk and talk normally. And she was diagnosed with cerebral palsy and a movement disorder later. And then she started to, and she was making some progress. She started having seizures at 10 years old. And she's had all the testing done, MRI and the genetic testing, and there was no specific cause found, unfortunately, which is sometimes the case. So what age would you start to discuss transition with Katie's family? So 12, 14, 16, or 18 years. So this is not a trick question. I think, as I mentioned in the first slides, we would want to make them comfortable with the idea of transition early on. So between 12 and 14 years of age is when you really want to introduce the process, not start discussing specifics about the transition, but start to get organized. So these same principles apply to Katie as they did to Kobe. We have the expectation of transition, introducing the transition policy in the clinic, and working through the checklist. And the yearly self-management assessment is instead prepared by the caregiver instead of, in the first case, it was prepared by the patient himself. So some things that mom mentioned when we asked her about the transition process, she would have liked to have known about the process sooner. So this was after these, she was already 23 in 2017. So when we approached her, she had already transitioned, and it was after these tools had been developed. And so, at our hospital, we have not been as organized preparing families for transition until these tools were available. And now we try to use a version of these with all of our patients, and each provider has to adapt it, slightly. But she would have liked to known about the process sooner. When mom was given the task of transition, she assessed many adult providers and the different practices, academic medical centers, private practices. And some of the things that she reflected on was that she knows her child better than anybody and can advocate. And that the Child Neurology Foundation resources provide an organized approach. From a child neurologist perspective, with a complicated patient like Katie, we really have to realize this is slow and can take several years to get all the pieces together. We're lucky that we have a large team in a children's hospital, and I think a person like Katie would probably be cared for at a larger hospital with multiple specialists. And all of these different specialists and all of these different organs that are cared for need to be transitioned to a completely different system. And we feel like, or we try to suggest that the pediatric team is here to help all the way along. And so that's our principle 6. So here mom was saying that she was comfortable after meeting the new physician, that they listened, and that they were ready to make a transition. The adult neurologist who is accepting the care of Katie should partner with the child neurology colleague to learn about Katie and to understand the plan of care. It's easier for the adult neurologist if there's a primary care doctor already established. So I think for both Kobe and for Katie, the initial step should probably be getting an adult primary care doctor. So a family practice doctor, internal medicine doctor, who would, if Katie's on, for example, I don't think this is true, but if she was on blood pressure medicine because of high blood pressure, for example, you don't want the neurologist to, have to be the only doctor who's, seeing her and possibly prescribing that type of medication. So it's important that they see a primary care doctor who could then refer to cardiology, or an adult doctor may be comfortable treating high blood pressure. Because epilepsy is really just part of all of the people who are involved in her care. And I'll just make a specific plug here for a patient like Katie, where we don't know the specific reason why she has epilepsy or her developmental delays. And she's had the latest technology in genetic testing, what's called whole exome sequencing. And she's had MRIs along the way. And I'll just point out the difference that, an MRI or an EEG is performed, say in 2016, a doctor read it, and that's pretty much it's a static or a final read. That's the way it was at that moment, and that's the way it is. The whole exome sequencing, we're learning more information about our genes every few months. Every 6 months, there could be a new gene associated with epilepsy discovered. So it's important as part of the transition to an adult care provider to for the parent or caregiver or the patient to remind the adult neurology caregiver to reanalyze or ask about the whole exome sequencing on a regular basis every few years. So again, I'm sorry you can't hear Katie's mom's final thoughts, but she's just summing up here that she's glad that there were resources from the Child Neurology Foundation website, and that will be very helpful for others going forward. So we've gone over the 8 common principles to assist with the transition of care. This is a backbone or a process that each provider and family will probably adapt to their child's individual situation, but it provides some concrete steps in order to make a successful transition. And we say that transfer is complete when the child neurology team has communicated with the adult neurology provider, and they've accepted the patient, they've made an appointment and made a follow-up appointment. The child neurology team is always there to answer questions going forward, but at that point they would say in the computer that or in the chart that the transfer is complete. So that's the conclusion of the slides, about 30 minutes. I wonder if, Ayesha, would you like to moderate the question?
Sure, yeah, I definitely have a couple questions that came through the chat.
Okay.
Around the 6:15 mark, we had a question about how can parents, so this topic is a very difficult, but yet very important topic, but there seems to be a bit of a bottleneck or a hurdle. So how can families who have not yet had this conversation, how can these families broach the topic on their own? What would you suggest for them? What are the talking points? We know the age that you suggested was around 12, but how do you recommend that these families start that conversation?
Well, and I can see the last comment here about nobody's talked to us about transition yet. And I think that there's a lot to cover in your first visit with your epileptologist or your neurologist, and in the subsequent visits too. There's probably a rush to discuss the pressing medical issues. So the carving out some time to discuss this in detail is important, especially later on in the as we're getting closer to the transition time. So if your provider hasn't already broached the topic, I would suggest that you go to the Child Neurology Foundation website. You can review the 8 principles yourself. You can download the tools or these worksheets, these writable tools, and you can present these to the neurologist at the next visit. And I think it would make a great talking point for I don't understand this point, or who's going to do this. So especially on the maybe I'll back up to the that worksheet that was back in the beginning. There's some questions on there where it suggested I'm gonna do this by next time, or I did it already, or somebody's going to do this. Who's it going to be? Making my own doctor appointments. Should that be, my mom? Should I do it myself? Should the doctor take care of that? I think these are things these are all questions that you can discuss with your doctor about transition. And don't expect to cover all this in one visit. I think, you may see your doctor or your child's doctor every few months or twice a year or once a year. And I think you want to chip away at these issues little by little every time that you have an appointment.
Great. Jennifer, I hope that answers the question. And if you have any follow-up questions, you can ask them or throw them in the chat. The next question came up around the 623 mark. So how long are EEG tracings usually kept on file in the pediatric office, and does that differ in adult practice?
Well, I think that there are specific rules that are probably dictated by the state of Illinois as far as how long any type of medical record needs to be maintained. And I don't want to misspeak and say the wrong number of years, but it is a number of years, and the amount of time that in past years it was on paper, and so the paper would obviously build up and would need to be discarded eventually. So there was a limit there. Now we have digital files, but those also take up space. There's immense amount of data, especially in the video. And so, storing that forever and ever and ever is not possible. So the answer is I'm not sure, but it should be many years, and it should be different for those who are over 18 and under 18. I think there is a difference in the amount of time you need to maintain the files. So that's probably a good question for medical records at your child's hospital.
It looks like a related question just came through about the issue of turning 18. So it says, how do we address the issue of when they turn 18? When my daughter turned 18, I no longer had access to the records. So would you again suggest that this person goes to the medical records office?
Absolutely. I think, depending on the, specifics, the daughter could request the medical records herself if she's unable to request the records because of some disability. Then the court usually is involved with providing guardianship to a parent or a responsible caregiver who then would have a legal right to request the records. Good question.
Just looking through, I think we answered, there were a couple of questions that were similar, so we knocked those out.
Well, I'll just speak for a minute while people are thinking of those things. So I wonder what people think about these worksheets. I mean, I think when I'm part of this transition project action committee, so I was in meetings where we developed these things and adapted them from the Got Transitions project, which is nationwide and for all patients from American Academy of Pediatrics to the American College of Physicians, the adult counterpart. And it's a little cumbersome to fill out these forms, to keep them somewhere. And when we thought about this, because we do everything in our electronic medical record, it's very daunting for the doctors to keep these things straight. We can fill them out, scan them into the electronic medical record, and there they'll be. But somebody has to fill them out. So I think that the doctors are busy, but I think more and more as I'm seeing some good feedback from I presume parents of patients. I think this is exactly right, and something that that the parents and the caregivers should perhaps, given these resources, then utilize them to steer their doctors in the right direction. They're trained to take care of epilepsy, and they're not necessarily trained in legal aspects and so on. We have social workers that help us, thankfully, but I think if the parents or caregivers can advocate and download these forms and bring them and provide them to their providers, that would be a great benefit to their child. Should I just read off the?
Yeah, I see your readings. If you want to go ahead and grab the next.
Yeah, it's working well. So any recommendations for guardianship questions? So depending on the age of the patient, we will, I think utilizing the social worker in the hospital or the hospital department is probably the best resource for knowing the steps for guardianship. You'll need to find a lawyer somehow, and sometimes the hospitals can point you towards lawyers who are happy to help. When the person is already 18, it makes it a little bit more difficult. But if it's questionable, what exactly that individual will be able to handle, or will be able to handle some questions, a detailed evaluation of the intellectual capacity and functional capacity is important. So those are usually performed by what we call a neuropsychologist. And somebody's saying about the county. So as a physician, I am not, I admit I'm not going to be able to rattle off, Cook County versus other county. The idea of, that a doctor can do everything is not really feasible. So I think these are great clues from families that they know best. And I think maybe I can just point them in the right direction, when they're 14 and, and their child, they're thinking, I'm not sure if they're going to be able to decide, right from wrong at 18. Maybe we should get that assessed and know whether I need to legally be in charge of things when they're 18.
There was a question up at the 6:39 mark. It's a really interesting question. So if you have multiple specialists, which pediatric specialist do you recommend transitioning first?
Well, that's a very good question. I think that we, although some parents have said they haven't heard about transition, even at our hospital, there is actually a quite an organized transition committee that involves all of the special subspecialties. And what I glean from those meetings is that everybody has a slightly different concept. So those individuals who have cancer, for example, they may stay with their child doctor for a longer time, or who are born with a heart issue might stay with their cardiologist longer, just because adult cancers and adult heart problems are very different from pediatric heart problems and cancers. So the adult doctors really don't have any or don't have training or don't have the expertise in these areas, and it can be hard to find somebody who is willing to take that on. So I think the time of transition will depend on what that specialty is. In other words, a kidney doctor, not that I know specifics about the kidney transition, but I can just imagine that you would have a similar sort of monitoring process for kidney disease in a child that you would have in an adult. Going forward, what was I going to say? The most important thing, as I had mentioned in the slides, was to get that initial primary care doctor. And so that person can then refer to their network. If they are an adult internal medicine doctor, they would have neurologists, cardiologists, and nephrologists, kidney doctors that they already work with in an established network. And so they can make these referrals, and they can assist with the transition.
Dr. Millichap, one quick question for you, and you might have mentioned this, but when you're having a conversation with your patients, do you often give names of adult neurologists that they should meet with? Like, are you very specific, or do you speak in a more general term, and just that this is the next step and that these are the options for you?
Right. So as I mentioned, if I refer to a specific doctor, that doctor's clinic may be very far away from that family's home. Maybe they don't have office hours that work for that family. They may not take their insurance, most importantly, probably the most important barrier. So I rarely will offer specific names. I'll ask the family, as I said, to find the internal medicine doctor, ask which neurologist they work with. I may, depending on the complexity of the patient, I may steer them towards major hospitals and hospital systems in Chicago. If they live that way, I might suggest, or on that highway, I might suggest they go to Rush, or more south, go to University of Chicago, or further out west, Loyola. It all depends on a lot of different factors, and that individual too, the patient, like Kobe, he should be able to decide where he wants to go. Does he want to drive all the way to the city to go to Northwestern, or does he want to go to a local doctor closer to where he's going to be in college, or where he's going to be working? It's very hard to give specific names, is the short answer.
Yeah, no, that's fair.
But we are in the process, and hopefully, can provide resources with a list of doctors, adult doctors, who are willing to accept patients. And so we send people one way, and their clinic is full, or they're not accepting complex patients from pediatric neurology practice.
Mm-hmm. And we at the foundation, we maintain a list of all of the different level 3 and 4 centers, so we can provide that list to anyone at any time. So it takes a little bit of the work off your hands. And we're happy to upload these tools. It seems like you've gotten really great feedback in the chat box, so that's great. And whatever we can do at the foundation to help you and help our parents, I think that's something that it's very easy for us to do.
Wonderful.
Well, are there any other questions, anything we haven't touched upon yet? I guess I'll take this minute to plug our next virtual chat, which is a month from now, at the same time, on February 23rd. So we're so happy everyone chimed in tonight, and come back again on February 23rd. And we're still finalizing our topic and speaker, but we hope to have an awesome presentation as well.
Well, thank you, Ayesha. I really was glad to be able to give this talk and to introduce these tools. They've been around for 4 years, but it sounds like people didn't know about them. So I think that's really a win. Over 20 people saw it, and they can spread the word.
Awesome. Great. Thank you, everyone. Have a good night.